Hi everyone, my name is Emily and I'm a nurse working in the Day Treatment Centre. Today we'll be discussing a common presentation that we often see in our ward, which is acneiform rash caused by cetuximab and panitumumab. In this presentation, we'll be discussing what acneiform rash is and how it is graded. We'll also have a chat about pharmacological and non-pharmacological management of this rash. Unfortunately, for many patients who do have acneiform rash, their quality of life can be severely impacted. We'll also be touching on this and how it can impact their cancer journey. So what is acneiform rash? So acneiform rash is a rash consisting of papules and pustules that do not have a whitehead or blackhead. On appearance, they look like pimples and generally do not burst. Despite its appearance, most patients are not bothered by it and are asymptomatic. However, they can be symptomatic for some patients, causing itchiness and tenderness, and may be weepy at times. Generally, this rash occurs on the face, torso, and back. In more severe cases, they can also pop up on the arms and legs. So, which therapies cause acneiform rash? Acneiform rash is caused by epidermal growth factor receptor inhibitors. The most common ones we see in Day Treatment Centre are cetuximab and panitumumab. We usually use these treatments for metastatic colorectal cancer patients, together with their treatment of FOLFIRI or FOLFOX. However, they can be given as a single agent as well. We rarely see the other ones, such as erlotinib and gefitinib, as they are no longer used for non-small cell lung cancer. Now that we know EGFR inhibitors cause acneiform rash, how does it occur? On our cells, tyrosine kinase receptors on the cell surface help with normal cell function. Epidermal growth receptor factors are a subclass of tyrosine kinase receptors. In tumour cells, EGFRs are often overexpressed. To combat this, we give EGFR inhibitors such as cetuximab and panitumumab. However, this inhibition of EGFRs can cause skin toxicities as epidermal cells are unable to proliferate and lead to increased apoptosis. This causes inflammation and infiltration from immune cells, which presents as the acneiform rash. As mentioned before, this rash normally presents on the face, torso, and back. Now we'll look at how acneiform rash is graded. Grading is important as it determines whether treatment should continue. Grading is based on the patient's body surface area that has been affected. Grade 1 is when the rash is less than 10% body surface area. For example, it would only be the face or only the torso. Generally, the skin would look pink and tender with no obvious papules just yet. In grade 2, the rash covers 10 to 30% of BSA. For example, we most commonly see this as the face, neck, and chest, or the face, chest, and back. At this stage, the patient can be asymptomatic or symptomatic, but as it starts to affect their physical appearance, it can limit some of their everyday activities, such as going out shopping. By the time it gets to this stage, most patients would have already been prescribed antibiotics. When acneiform rash becomes more severe, we reach the grade 3 and 4 stage. This is when the rash covers more than 30% BSA. As you can imagine, this can affect the patient's ability to do ADLs, such as showering or putting clothes on. At this stage, the rash may have spread from the usual face, chest, and back to the legs or abdomen. The patient should already be on antibiotics by this time and may need IV antibiotics if the rash erupts and causes infection. Patients can still have their treatment at grade 3, but may be suggested to pause at grade 4. The most important thing to note about treating acneiform rash is that there is no curative treatment unless the EGFR inhibitor is stopped. Because of this, we characterize management as preemptive or reactive. Preemptive management means that we treat early because we know the rash may form at some point in the future. Reactive management is when we start these therapies once the rash has already formed. Most treating teams know we can help delay the onset of the rash, but we cannot prevent it from happening, and thus a preemptive management is often preferred. Despite not being able to prevent it, this doesn't mean that it will progressively get worse, as it can downgrade from grade 3 to grade 2, etc. If the rash is quite obvious, most patients would already be on doxycycline, which is the main pharmacological management for acneiform rash. Other supportive medications, such as analgesia, may be required if there is pain associated with the rash. However, at the end of the day, the treatment can be delayed, which can reverse the acneiform rash. Alongside pharmacological management, we should educate all patients on non-pharmacological management strategies. The main goal is to maintain a healthy and strong skin barrier and mitigate any side effects from topical treatments. These can include topical steroids such as hydrocortisone cream or topical antibiotics. We should encourage patients to moisturize while using steroids to avoid dermatitis. Other strategies are listed here, such as avoiding sun exposure, showering with cool or lukewarm water, and avoiding environments that can make the skin sensitive, such as saunas, hot baths, and vigorous exercise. An important topic that I want to touch on about acneiform rash is the impact of the rash on patients. The physical and psychological burden of the rash on patients is often something patients do not discuss with us, as they are often afraid that it might stop their treatment and have adverse effects on their treatment outcomes. Another thing to note is that men are less likely to use skincare products than women, and gentle reminders to our patients that it is important to maintain their skin integrity to minimize the effects of the rash. As we all know, antibiotics can cause side effects such as diarrhea. The use of antibiotics to treat acneiform rash can cause diarrhea and thus affect compliance. This is something that we need to acknowledge, as the patient may be going through a myriad of other chemotherapy-related side effects as well. Finally, it is also crucial to educate our patients about the occurrence of acneiform rash, as at least 85% of patients will eventually have EGFR inhibitor-induced acneiform rash. When we educate them early, they can be more expectant of the side effect and understand that it cannot be prevented. To put together all the information we have learnt, this is an example of a presentation that we often see in day treatment centre. So we have a patient that presents with acneiform rash on cycle 3 of their treatment on cetuximab and FOLFIRI. We can see that they have an itchy rash on the face and chest, but no ruptures, and does not moisturise. As part of our ISBA handover, if we need to escalate this to the treating team, we can firstly grade the acneiform rash by looking up the rule of 9s. As this rash is on the face and torso, we are looking at 4.5% plus 9%, making 13.5%, which falls into grade 2. By grade 2, we know that they may have already been started on topical steroids or antibiotics, and this is something we should ask. If they haven't been on any treatment, we can escalate this and recommend doxycycline or topical steroids. There is generally a very low threshold commencing doxycycline for those with acneiform rash, as it is known to present quite early and is a common side effect. We can also recommend loratadine for the patient's itch. If the patient does not generally have any skincare routine, we can educate them on general advice about improving their skincare. To finish up, these are a few points about how we can improve our care to patients with acneiform rash. We can easily grade acneiform rash by determining the BSA affected. The rule of 9s can easily be found on Google, and it's not something we need to memorize. During our assessment, we can check if the patient is on any antibiotics or steroid creams and what their skincare routine is. As always, we can escalate to the treating team if we are worried. Thanks everyone for listening. Hope you have learnt something from this presentation that you can bring to your practice.